Psychology.
It had to be a little bit. I did that withdrawal button. What? No. That's right. They did make it clear, but that research said it was our brain.
Yeah.
Well, that made it worse.
Gotta write a change the date. If there's a topic that we're like interested in, I mean, this is how you can ask.
Mhm.
Oh, cool.
Yeah, so you want to make sure that there's a lot of articles available before you pick your topic. So yeah, you can let me know. Yeah, I go through the respiratory care journal and I look to see what's being reported on. And that's where I get most of the topics. Yeah, if you're finding something that you're interested in, and it's meant to be, and I don't know, picking like cystic fibrosis, if you're interested in cystic fibrosis, it's not about reporting on a disease. It's more about reporting on what's current in the field of respiratory care. So if there's like a new treatment for cystic fibrosis and you wanted to go into details about that, you could do that. But it's not about teaching a disease or I guess that's a good example of what I would say. That's not what the topics are for.
Like a peer review, almost, like you're reviewing articles, right?
Yes. Yeah.
One of my therapists was telling me that they came out with all those research how much vitamin D helps COVID people. So like,
Excellent. Yes. Yeah, that would be very good. Yeah, I think one of the topics last year was magnesium for asthmatics and how much magnesium is like stopping their bronchospasms. So yeah, vitamin D would be excellent. All right, so we'll start talking about high frequency ventilation, and it's showing the two high frequency ventilators that you're going to be seeing with sometimes adults, but mostly neonates and pediatrics. And let me give you a definition for high frequency. It's ventilating at high respiratory rates. We're talking 150 breaths per minute up to 900 breaths per minute. That's really fast. So when you're breathing that fast, the tidal volumes are really small. It says the tidal volume is less than dead space. And we know if we don't have an adequate size tidal volume, we're not getting alveolar ventilation. We just get air moving in and out of the conducting airways, and there isn't enough to fill the alveoli. So with conventional ventilation, we're always thinking, oh, we want our tidal volumes to be 4 to 6 mLs per kilo. We want to make sure that, you know, we're getting good alveolar ventilation. And then we switch over to high frequency, and the tidal volumes are so tiny that there isn't enough to fill the alveoli. So how in the world are we able to get rid of CO2 with such small tidal volumes? So there's all these fancy mechanisms as far as how does gas exchange occur when the tidal volume is just too small to wash out carbon dioxide. So it mentions direct bulk flow. That must mean like a bulk of the air going down the conducting airways. Longitudinal dispersion and Taylor dispersion. I can't even fake that one. Penduloft, it shows how when the heart is beating, that's causing air mixing at the alveolar level. Asymmetric velocity profiles, can't fake that one either. Oh, here's the cardiogenic mixing. And then the last one, molecular diffusion. So that one I can describe to you. When we have carbon dioxide in our alveoli, the carbon dioxide molecules are moving at a rapid rate, and they'll disperse into the conducting airways with nothing happening. So it's just the movement of molecules. Same thing with oxygen getting down into the alveoli. You've got molecules of oxygen moving around. The molecules will make it down to the alveoli and then into the blood. So do you think on your test it's going to say list the six mechanisms of gas exchange? No, if your professor doesn't know it, it's not on the test. There's two types of high frequency ventilators. The first one it mentions is high frequency oscillatory ventilation. And yes, we use an oscillator to ventilate the patient. The oscillator has a diaphragm and a piston to move the air in and out of the lung. Let me go back to the first page to show you a picture. So you can see the diaphragm, this large black circle. It looks like a speaker almost. And behind that diaphragm is a piston, and it pushes the diaphragm forward. And then for exhalation, it pulls back. And what it's doing is it's pushing air into the circuit, and then it pulls the air back out of the circuit. So that's how an oscillator works. And it says exhalation is active. So when the piston goes backward, it's actually pulling the air back out of the circuit, and it obviously pulls it out of the conducting airways. So that's what makes an oscillator different than jet ventilation. With high frequency jet ventilation, the ventilator delivers very short, high pressure jets of air, and the exhalation is passive. Oh, it doesn't show the adapter on this picture. So this is just the box where you put in your settings. It's not showing the circuit on this picture. So it's hard for me to show you where the puffs of air are being added. But I can tell you, you know, the adapter that we take off with, once we intubate the neonate, we take off the adapter and then we put on that adapter that allows the Ballard to be connected, and then the ventilator circuit. Yeah, it looks like a Y. So it's an adapter. This adapter has an extra port, and that's what you connect the jet ventilation up to. And it shoots these puffs of air into the endotube. So that's how a jet ventilator works.
When you say an exhalation is active or passive like that?
Active exhalation is the ventilator is pulling the air back out of the circuit and the conducting airways. Passive exhalation, that doesn't happen. So air has to leave on its own. Who needs high frequency ventilation? It works really well with air leaks. So when we have a patient who has a ruptured alveoli, and ends up being a bronchopleural fistula. So we push air in with the ventilator, and a lot of it goes out this hole in the lungs and goes into the chest tube. And when we see that we're losing, you know, half of our tidal volume, that's going to start compromising the ability to ventilate the other good lung. So when blood gases start getting really bad, what are your choices? You can't keep ventilating if there's this big hole. But if you switch over to high frequency ventilation, you'll still be able to ventilate, even though you had this hole present in the lungs. Pulmonary interstitial emphysema, there is air migrating from the alveoli and into the interstitial spaces. And to let the alveoli heal, it's better to put them on high frequency ventilation instead of keeping them on conventional ventilation. And next one is failure of conventional ventilation. So we talked about patient, if we're ventilating them with PRVC, we try pressure control, we try bivent, and we're still not able to ventilate them. You know, we've got an acidotic blood gas, our O2s are 85% saturation. What do? So that's another indication for using the high frequency ventilators. The oxygenation index, have you seen this already? You have? A long time ago? Oh, you do it on your patient assessments, I think. Okay. So you use the FiO2 as a percent, multiply by the mean airway pressure on the ventilator, and then divide by the PaO2, and you come up with the oxygenation index. It's kind of like PF ratio opposite, isn't it? PF ratio, looking for ARDS, you do the PaO2 divided by FiO2. It is used for ECMO. Yeah. So you've used the PF ratio. Take the PaO2 divided by FiO2, and depending on where the number falls, you've got mild, moderate, or severe ARDS. All right, so now with using the oxygenation index, it's opposite. FiO2 goes on the top, PaO2 goes on the bottom. But the difference is you also have to multiply the FiO2 by the mean airway pressure. So if you plug in normal numbers, what is the oxygenation index? Let's use an FiO2 of 21%. Mean airway pressure, normally, if somebody has normal lungs on the ventilator, it's like 10 centimeters of water. And if they're oxygenating well, we're going to have a PaO2 of 100. So 0.2 times 10 is 2. Doesn't it come out to some fraction of less than 1? 100 is 10. So 0.21, or it says to multiply by 100. So 21 times 10 divide by 100. Yeah, I get 2.1. So that's normal. If it's greater than 19, that's pretty bad oxygenation. So how bad would everything have to be to come up with a number greater than 19? Let's put in some bad numbers. All right, so 0.6 or 60. All right, so we'll use a mean airway pressure, 25. That's pretty high. And then divide, how bad is our PaO2? PaO2 is 40, okay? We get an oxygenation index of 37.5.
They're dying.
They're dying. Is that a show a need for high frequency ventilation? Yes. Yeah. Was that a good review to just mention the different terms that belong in there? Okay. What's that, Brent?
That's yours.
Well, it means you have to write down the mean airway pressure, and I don't think
Which that's on the.
it's on the vent, but it's never part of what you document, though, right? Oh,
The P.
you threw that away? You don't throw things away. You probably lost it. No, do you really? Oh, my word. It's a good thing Jason didn't dump it. So looking at on the bottom left are collapsed alveoli. And then once the alveoli are kept open, they stay open. And that's what it's shown, the progression of getting the alveoli open and then keeping them open. So that's the goal for high frequency ventilation. I don't know if you hear that word like open lung tool. I think you do with the servo ventilator, open lung tool. It's not really opening the lung. It's just opening the alveoli and keeping the alveoli open. So the problem with conventional ventilation is that we're damaging the alveoli when we're ventilating. We overstretch the lungs. It says that with stretch, we alter capillary transmural pressures, just pressures across the capillary. Relaxation changes in transmural pressure causes breaks in the capillary, endo, and epithelium. So we have little tears in the alveoli from overstretching them is pretty much what it's saying. And when you get a little tear in the alveolus, you get a leak of proteinaceous material, wipes out the surfactant, and now your alveoli collapse. So this is showing little tears in the alveoli, and now you see white blood cells coming into the alveolus, white blood cells. They are white on the picture, but they're red if it was a color picture. You see red blood cells coming into the alveoli, and that's because of the tearing of the alveoli. So how does high frequency ventilation prevent this ventilator-induced lung injury? And it prevents it by maintaining a constant mean airway pressure. So kind of like PEEP, but not exactly PEEP. So with high frequency ventilation, it's like blowing up a balloon and keeping the balloon inflated. And while it's inflated, you're pushing air in and out of the balloon. That's kind of like what high frequency oscillation is like. Blowing up the balloon and you're keeping it inflated. That's keeping your constant mean airway pressure. And then you ventilate in and out of it. I don't know if you guys are going to last. It's always Tiffany and Whizbean that are asleep by the end of everything. So this is a really good picture. Can you see the black line? I don't know if it shows up for you, but it's showing the ventilator pushing a breath of air into the lung, and up here it says PIP for peak pressure. And then during exhalation, it comes down to your baseline pressure or PEEP. And then it's showing high frequency ventilation on top of that. So with high frequency ventilation, you set your mean airway pressure and you keep that pressure constant. And then you're going to push air in and out of the lungs as you keep that mean airway pressure constant. And this is showing lungs that were completely deflated. And then you increase the mean airway pressure, you pop open the alveoli, and even when you go down on your PEEP, doesn't show it going down, does it? Inflation, deflation. Okay, so here's 20 of PEEP. And then as you turn down the PEEP from 20 to 16 to 12 to 6 to 4, you see the difference between the collapsed lung before inflating and then after keeping pressure in the lungs and how it stays inflated. You guys did this in your lab.
Yeah.
In mechanical ventilation. In your pig lungs, yeah. You want to do that? I'm okay with it. Yeah, everybody wants to touch it, so you have to take a box of gloves with you. And tell them they got to put the gloves on first in order to touch the lungs.
That would attract me. I'd be like,
What? You can. Yeah, I've got like an old one. The new one hasn't arrived yet for January, but it's supposed to be here, but I can give you the old one. Yeah, you can hook up the ambu bag. There's like, it looks like Legos or Tinker Toys or something where you can bag air into the little pipes and it inflates the lung. Yeah, they love it. All right, so what are settings on the ventilator? So we're starting off with settings for oscillation first. And then I think it's next week's lecture, I give you the settings for the jet vent. So first setting is amplitude. And this relates to conventional ventilation when we're setting our peak pressure or delta P, or inspiratory pressures. So amplitude is the same thing. So the more amplitude you give, the bigger the tidal volume. The amplitude is measured at the endotube, but the amplitude, the peak pressure that we see, it never reaches the alveoli. I'm going to put that in the chat. This pressure never reaches the alveoli. So when we set an amplitude or a peak pressure on conventional ventilation, if you're going to put your patient in pressure control, what is like a starting inspiratory pressure you would use? 20, okay. All right, so 20 is a good starting pressure for pressure control. And then for setting amplitude on the oscillator, yes, you can start with 20 centimeters of water, but that's not the whole story. You increase the amplitude until the chest is wiggling. Do you like that? You're looking for the chest to be wiggling. And when the chest is wiggling, you've got the right amplitude. If the chest isn't wiggling enough, you don't have the right amplitude. If the legs and the thighs start wiggling, you've got too much amplitude. Then you turn it back down again. All right, so this is a good picture to show you how the pressures that we set on the oscillator don't reach the alveoli. With conventional ventilation, it does. The peak pressure, we do a plateau and we can see what the alveolar pressure is. With high frequency ventilation, most of that pressure gets lost as it goes through the conducting airways. So it tells you over here on the left, only 10% of the amplitude reaches the alveoli in adults. Only about 1% of the amplitude reaches the alveoli in neonates. So that it's, you're starting off with this big amplitude, like these big pressure swings at the endotube. And then as you get into your medium-sized airways, it's reduced. And then by the time you get to the alveoli, even more reduced. I have a vocabulary word for you guys. Attenuation. Attenuation. And it just means diminishing over time. All right, so you get a blood gas and you need to change your CO2. What setting do you change on the oscillator? And the answer is amplitude is 1. And it kind of goes hand in hand. You see how it says to change the CO2 2 to 4 millimeters mercury, change the amplitude about 2 centimeters of water. So they kind of are the same. If you want to drop the CO2, then you would use less. You would increase your amplitude. It should be upside down, right? Okay, it has a question mark. Let me draw. So to get rid of CO2, which arrow should I draw? Up or down? Yeah, to blow off CO2, you need more amplitude. Just like in pressure control, the more pressure you have, the bigger the tidal volume and the more you'll blow off CO2. And then this is supposed to be increase. Oops. If the CO2 got too low and you want to increase the CO2, decrease the amplitude. So that you can bring that over from conventional ventilation. So that theory sticks. In order to get the amplitude, there's a knob on the oscillator called the power setting. And as you crank up the power, you're cranking up the power to the piston. And a really high power is just going to make the piston go really hard and really fast. And to obtain chest wiggle, you increase the power, which increases amplitude. All right, so showing the front of the oscillator and looking at the amplitude, and then in this little window, it's showing that power knob where you crank up the power to get your amplitude. So you have the connection between power and amplitude. Here it says for adults, you start with, nope, that's not right. So we're going to leave that part till later. It tells you to document the power setting on the ventilator flow sheet when doing bedside rounds. What will cause amplitude pressure to drift higher? The back pressure will cause an increase in amplitude, and it gives you an example of what that's talking about. If the lungs are getting worse, or there's an increase in airway resistance, it's going to make the amplitude go higher. kind of like having a patient in volume control. When their lungs get stiff, it takes higher pressure. If there's airway resistance, it takes higher pressure. So that's the analogy I want you to remember. I hope these words are good. So with stiffer lungs or increases in airway resistance, the amplitude will increase on its own. That makes sense? So, gosh, it's going back like before COVID. So that was 20. So maybe in 19 or 18, the company rep came and was giving us a lecture on high frequency oscillation. And he was telling us how at the hospital, everybody chases the amplitude. So the doctor writes the order for amplitude instead of an order for, chest wiggle. And if they order an amplitude of 20 centimeters of water, and you go to check the oscillator and the amplitude is 24 centimeters of water, what everybody does is they turn down the power to get the amplitude back to 20. And he said, that's the wrong thing to do. You shouldn't be chasing your amplitude. That should not be the physician order, is to order the amplitude and it stays at one number. You should expect the amplitude to go up if you've got stiffer lungs. So yeah. It's an indicator. With after the blood gas is attained, change amplitude to target a certain CO2. That would make sense. But when you're, I don't know, when you're putting them on the oscillator, it's better to increase amplitude until you see good chest wiggle. So I'll give you guys a break in a second. Let me see if this is still linked up. No, oh, I'm so sad. Okay, I'll stop the recording and give you guys a 10-minute break. Whizbeam, Tiffany, you've got to run around the building 3 times before you can come back in this classroom. All right, so we're talking about ventilator settings on an oscillator, and we talked about amplitude so far, and now we're going to talk about the next setting, which is, instead of calling it the respiratory rate, you call it hertz. And for every 1 hertz, it's 60 breaths. So typically with preemies, you're going to start with a really fast hertz, like 15 hertz. So if you turn it to 15 hertz for their respiratory rate, how fast is their respiratory rate going to be if 1 hertz is equal to 60 breaths? That was quick, very good. 900 breaths per minute. Isn't that incredible? 900 breaths per minute. That's how fast you ventilate preemies. And then as the organism gets bigger and bigger, you're going to use lower and lower hertz.
The organism. Like the person, like the baby.
Well, we could be talking about giraffes and kittens. As you turn down the hertz, the tidal volumes become bigger. So fast hertz, little tidal volume, slow hertz, big tidal volume. And it tells you and explains it. When you lower the hertz, you increase the tidal volume because you have a longer inspiratory time and you have a longer exhalation time. So it's longer for air to be exhaled and also longer for air to be inhaled. It says the piston moves a greater distance when you have a lower hertz. The frequency controls the time allowed for the piston to move. More time allows the piston to move a further distance. Therefore, the lower the frequency setting, the greater the volume displacement. Are you getting the connection between the two? You slow it down, you get a bigger tidal volume. Faster, you get a smaller tidal volume. That's what the picture is trying to show you. Here it has 8 hertz versus 6 hertz. With 8 hertz, if you look at the total cycle time between inspiration and exhalation, you can see how it's shorter. With 6 hertz, there's just a longer time for the piston to move, and you get a bigger tidal volume. So hertz or frequency affects the tidal volume. Here it's showing on the front, you turn the knob and you get a frequency of 10 hertz. Why is it showing that? Oh, I see, it's up at the top. I can't move it out of the way. Frequency controls pH CO2. So now we've talked about 2 different settings that control CO2. One was amplitude, and then this one is the frequency. You would think they would make the oscillator more exciting to look at, you know? I mean, the front of it is just really boring. You know, the black little frame, the black knob, this beige background.
It just looks boring. It doesn't sound.
It looks but not sounds. Oh, okay. It does. You're right.
And you still have to calibrate it.
And it is old. So 2000, 2005. So 20 years old.
No. You still gotta calibrate it. It has it up there.
You had to do it? Oh, okay, very good. As far as where you should set the hertz or the frequency, this is not something to memorize, but just notice again how if you've got a preemie weighing less than 2 pounds, you use 15 hertz, and then as the organism gets bigger, you use a lower and lower hertz. So for adults, 6 hertz, sometimes 4 hertz. So frequency does contribute to the CO2, but you pretty much leave the hertz according to body weight. Does that make sense? Yes, changing it could change your CO2, but that's typically not what's done. Typically, the amplitude gets changed and the hertz stays the same. And then the second bullet says frequency is not weaned as is done with conventional mechanical ventilation. So it's not like you start off your preemie on 15 hertz and then you wean them down to 12, 10, 5. And when you get to 6 hertz, they're ready to come off. No, because they would explode if you did that. Not really. But lowering the hertz, remember, it gives a bigger tidal volume. So you don't wean the hertz. Hertz basically goes according to body size.
So like ideal, ideal body weight or.
Yeah. If CO2 is high, turning down the hertz is considered a last resort. All right, so that was the second setting, and now the third setting is mean airway pressure. So the mean airway pressure is used as distending pressure. It's similar to PEEP, but it's not PEEP. And the reason it's not PEEP is at the end of exhalation, you know how our pressure goes down to baseline or down to PEEP? With high frequency ventilation, it's not like that. Your ventilation occurs above the mean airway pressure and below the mean airway pressure. So you never get down to any baseline. Mean airway pressure improves oxygenation. So that's kind of similar to PEEP, right? If we wanted better oxygenation with PEEP, we went up on the PEEP. If you want better oxygenation on the oscillator, you go up on your mean airway pressure. You adjust your mean airway pressure according to the level of the diaphragm on chest X-ray, and here it's only mentioning infants. So with pediatrics and adults on oscillation, you just look for the X-ray to improve. You don't look for the diaphragm to be at the 9th to 10th rib. So I guess that's why it's only specifying for infants. You adjust your mean airway pressure until you see the diaphragm at the level of ribs 9 and 10. So to get your mean airway pressure, you're going to crank up bias flow. And the bias flow has a flow meter with it. It'll show you a picture. And then it recommends some flow rate guidelines. So preemies 8 to 15 liters per minute. And that wasn't being followed for the longest time. And if you turn up your bias flow higher than 15 liters per minute, the babies can't exhale against all that flow. So their CO2s start to climb. So again, you want to limit your flows, just like we were talking about with nasal CPAP or with nasal CPAP. Too much flow makes it hard for them to exhale. Bias flow flushes exhaled CO2 that is actively pulled back into the circuit during the expiratory phase. All right, so here's your flow meter. And as you crank it up, you're increasing your mean airway pressure. And it achieves the mean airway pressure because you're going to have a little valve in the circuit that I'll show you at another time. You set the I time at 33%, and it always stays at 33%. That's nice, right? You don't have to think about it. Just set I time at 33%. It doesn't matter if you're an adult, a preemie, a pediatric. What is the I time? 33%. You could adjust it. So since we're not adjusting it, can we skip this? Recommended inspiratory time, 33%. Okay, we'll take that and we'll move on. I time, 33%. It says you can increase I time to a higher percent for larger pediatrics. an increased inspiratory time helps with lung recruitment, but we're going to remember 33%. Does anybody want some extra credit? I knew he'd open up his eyes and look up. 10 points for extra credit if you watch a boring video and you stay awake during the entire video and take notes. It's due in 2 weeks. So where is the link? Where is the link? Oh, my word. If you, yeah, what if you do get to the wrong one? All right, so I'm gonna have to send you guys the link. Because I have, it's the 3100B, part 2 YouTube video, but what if there's a bunch? So I'll send you the link. Okay, and then for the last slide, I just want to compare conventional ventilation ventilator settings with high frequency ventilator settings. So in the middle, for controlling CO2 on conventional ventilation, we have rate, tidal volume. If we're in pressure control, changing our pressures give us a tidal volume. So that's what that's how we control CO2 with conventional ventilation, rate and tidal volume. With high frequency ventilation, we use hertz and amplitude. And pretty much since hertz doesn't change a lot, we use amplitude. But just to know, changing hertz can change CO2, changing amplitude can change CO2. Good so far? Okay, and then for oxygenation, we know changing FiO2 and PEEP with conventional ventilation will help with our oxygenation. On the oscillator, we change mean airway pressure and FiO2. So if you look along this right column, you see your settings for high frequency ventilation or oscillation, hertz, amplitude, mean airway pressure, and FiO2. Should I have just started the lecture here and told you that, and that would have been good enough?
No. Well, that's not good. This is something.
Oh, okay. Points. All right. We'll switch over to our last lecture for pulmonary function. Let me end this show.